Within the spectrum of congenital heart disease, there is tremendous variation, both in the anatomy of the disease and in the physiology. Decision-making in many complex cases, from clinical experience alone, is simply not enough to always know the best course of treatment or how to reconstruct a heart to achieve the best possible outcome. Even though the cardiovascular system is complex and there are biological underpinnings to its intricate function, understanding how to repair congenital heart disease is fundamentally a physics problem. At Boston Children's Hospital, we've put together an engineering team that utilizes proven modeling and simulation tools from industry to really change the paradigm on how several congenital heart defects are visualized, the procedures are planned, and operations are conducted. The impact of this effort has been reaching, in that this approach is now part of the standard practice in the care of many patients. And yet, we know we are only scratching the surface of what is possible with these techniques. Fundamental to our progress has been a partnership with Dassault Systèmes to extend many tools and platforms that are indispensable in aerospace and other fields and apply them to the challenging engineering problems that we face. I'm excited to share with you some of the successes we've had and a glimpse of what is to come.
Today I'll discuss the utilization of 3D models and computational simulations to improve operative planning for pediatric cardiac surgery. We have developed computational methodology both in the visualization and planning of complex surgical repair. We are utilizing computational tools to make decisions on how to best repair these children. This clinical workflow utilizes CT scans and MRI images from patients with heart disease. And from that, we're able to create patient-specific models of the anatomy. We utilize CATIA and other modeling software to digitally model surgical options. We then combine this data with information about the patient's circulation, including pressure and flow information from the MRI and catheterization procedures, and then perform computational fluid dynamic simulation on these patients. Centrally important to the modeling and simulation work we have done at Boston Children's Hospital has been to assemble a team of talented professional engineers that work incredibly closely with our surgeons and cardiologists. Our team has world-class expertise in the segmentation of cardiac anatomy into patient-specific 3D models. We utilize Dassault Systèmes 3D design software to digitally design and simulate the surgical procedure. Our team has modeled over 100 clinical patients at Boston Children's who have undergone operations or catheter-based interventions. I'm going to share with you some of the things we're able to do for these patients through the experience of a few of the complex patients we have recently treated. Michael is an 18-year-old young man with complex congenital heart disease where he only has one ventricle that works. He's had a series of several surgeries where the circulation has been reconstructed such that his one ventricle pumps blood to the body and blood coming back from the body passively drains into the lungs. This is a low energy system returning blood to the lungs, and it is incredibly dependent on an efficient pathway. Unfortunately, Michael's response to growth over time has resulted in dilation of his right atrium in the pathway where the blood returns from the lower body back to the lungs. This has created a large energy sink, and he's developed multiple complications. The challenge for us in helping create a plan for Michael was that where his right atrium connected to his pulmonary arteries, there was a very large diameter difference. We were going to use a 20 millimeter graft for his to reconnect the blood flow from his lower body, but to a 40 millimeter opening in his pulmonary arteries. Our challenge was to create a smooth connection with a minimal amount of energy loss. Without engineering tools, typically a surgeon would just make up in the operating room whatever patch or reconstruction they saw fit and hoped it resulted in relatively smooth flow and a balance of blood flow to both lungs. Sometimes this goes well, and sometimes it does not. The approach we took in this patient was to design a transition from the 20 millimeter vascular graft carrying blood flow from his inferior vena cava to the 40 millimeter opening in his pulmonary arteries. After we designed the cuff, we utilized computational fluid dynamics to optimize the cuff position and shape to achieve a low energy loss and a good balance of blood flow to both lungs. As engineers, we looked at this cuff design and found it a very reasonable and good solution, but translating that concept to the operating room in mind and crafting a cuff from a flat piece of patch material is simply not feasible. We utilized the CATIA platform to both design the shape of the cuff and then perform the unfolding of the cuff to a flat shape. With the help of Ryan Benishek, Rainey Richardson, and the CATIA team, we were able to unfold this cuff into a two-dimensional shape that was utilized in the operating room to create this from a flat patch of material. The patient underwent this high-risk operation, and the assembly of the cuff went very well. The result of the operation was a smooth curvature between the graft and the native pulmonary arteries. This patient's had a very good outcome and certainly would not have happened without the use of these terrific engineering tools for this patient. Another great example of how we're using these tools in cardiac surgery is illustrated by this patient. Allie is a 9-year-old girl who also has complex single ventricle heart disease, and she's had a series of operations and catheterization procedures to direct blood flow from her body directly to her lungs and have her one ventricle pump blood to the body. Because of her complexity, after her most recent surgery, all the blood flow from the liver was directed to the right lung. She developed vascular changes in that lung, and most of the blood flow went through that lung without picking up oxygen. Allie's having continual decrease in oxygen saturations down to a very low range with poor exercise tolerance. Without a solution, Allie certainly would not have survived for another year or two. We used a patient-specific model and the hemodynamic data from a catheterization procedure and an MRI, and we modeled Allie's blood flow and saw that all the blood flow from the liver went to the right lung. What we needed to do was to design a reconstruction approach so the blood flow from the lung would be evenly distributed to both lungs. With this, the left lung would heal vascular abnormalities and deliver more oxygen to the blood, and her overall oxygen saturations would improve. What we do now is to utilize a digital platform to perform these surgeries in complex cases with just the right curvature and the details of the reconstruction exactly as we would do it in the operating room. These patient-specific surgical approaches can then be evaluated with computational fluid dynamics to predict the outcome and optimize the approach before the surgery. This allows the team to choose the best reconstruction approach and refine the plan. This case illustrates the realities of how complex these patients can be. The approaches recommended by several surgeons and cardiologists were all wrong. Each of our recommendations resulted in all the blood flow going from the liver to one lung or the other. In this case, the first three options we modeled were ineffective over a range of normal physiology. And it was only with the power of computational workflow we were able to design an operation that achieved balance of blood flow we were looking for. This patient's operation went very well, and she made a terrific recovery. She has recovered function of the left lung now to the point her saturations are in the low 90s with no oxygen support. Here are images from a post-catheterization procedure and MRI, which show good flow from the liver to both lungs and very good congruence between the predicted lung flow by computational fluid dynamics and the measured lung flow by MRI. Not all of the evaluation and analyses we perform on these patients require computational fluid dynamics of patient-specific models. We're also utilizing these engineering tools to design complex curved patches that are positioned with the heart and visualize heart structures in a way we never could before. This is the heart of a young boy with very complex heart disease, requiring repair of a hole between the two ventricles or pumping chambers that sits right beneath the atrioventricular valves of the heart. It is essential in these patients to have these patches in the perfect location to allow unobstructed blood flow out of the right and the left ventricles. This is a curved patch that was created to thread the needle between blocking the right ventricle outflow tract or the left ventricle outflow tract. He underwent this complex repair with these tools to reconstruct his heart and achieve normal physiology. He recently celebrated his first birthday, and he's walking and thriving. This is a great example of how we use these tools in visualization for planning and intraoperative guidance. This is a complex heart of a patient who has multiple defects in the ventricular septum which is the muscular wall between the left and right ventricles. This can be a particularly challenging problem and can be hard to visualize these defects in the operating room. This tool shows the surgeon in a view similar to what they will see in the operating room precisely where these defects are. This patient's heart was reconstructed with each component being a different color. The components can then be turned on and off as needed to achieve different views. In this case, the right ventricle blood pool is in yellow and the left ventricle blood pool is in red. In this heart, the ventricular septum will appear in silver. As the heart is rotated and components are turned off, the surgeon sees the ventricular septum as they would see with the right ventricle open. The muscular ventricular septal defects are visible through the left ventricle as defects in the muscular septum. This has been a real game changer for us. This approach is used in all patients with multiple muscular ventricular septal defects at Boston Children's Hospital. One very important problem we are currently tackling is aortic arch reconstruction in newborn children. It is common for newborns to have a narrowing of their aorta near the end of their aortic arch or throughout the aortic arch, even into the ascent aorta. As this is the blood vessel that connects directly to the left ventricle and delivers blood to the body, it is essential to get this right to minimize the workload of the left ventricle. Enlarging these aortas in the operating room to normal size and shape is a complex three-dimensional problem. Surgeons fashion patches out of flat patch material, but to work perfectly, these patches need to curve in multiple ways. In essence, the reconstruction has to be perfect, as too narrow or too large of a reconstructed arch is a problem, either stenosis or an energy sink. Without any technical guide, the current outcome of these arch reconstructions is quite variable, as one might expect. We have worked closely with the CATIA team to develop a workflow utilizing this platform to pre-design patient-specific arch patches. This will truly be an extraordinary advance for these patients. One can see how we are taking the guesswork and variability out of figuring out the patch size and shape in the operating room. Here the patch is designed and also flattened so it can be transferred to a patch material in the operating room. Borrowing another common aerospace tool, we are in the process of mounting laser projectors in the operating room to translate these arch shapes to the patch material. We plan on having this arch reconstruction workflow within patients in the next several years. We are partnering with the FDA, Dassault Systèmes, and other partners to develop a workflow for the FDA to incorporate simulation of medical devices as part of the device approval process. In this in silico clinical trial effort, we aim to reduce the cost, risk, and timeline of clinical trials for medical devices. In this pilot effort, we are developing a computational model of the left ventricle and mitral valve. This collaborative effort has yielded a terrific model that we're excited to test virtually with a mitral valve repair device. A final example of how we're using some of these advanced tools has been a terrific collaboration between our team and Steve Levine and the Living Heart Project team at Dassault. This is a normal heart anatomy that has been replicated by the Living Heart team. Together with the CATIA team, we started with the exquisite normal heart model created as part of the Living Heart Project and morphed it into a model of tetralogy of flow, a congenital heart defect. This is a common congenital defect that has many aspects and requires a complex surgery to repair. In this model, one can clearly see the ventricular septal defect as well as the long narrowing below the pulmonary valve. We are enthusiastic about using these models both as predictive tools and guidance in the operating room, but also as teaching tools for patients and families facing repair of congenital heart disease. Here is an example of how we have used a model of congenital heart disease to explain the details of a heart defect to a family. This child has a ventricular septal defect, and the parents are learning about the defect and upcoming surgery through an interaction with a surgeon utilizing a 3D model with the heart defect on a holographic 3D screen. We are excited about these tools revolutionizing not only how we care for patients with heart disease, but also how we care for the families before and after surgery and make their process of undergoing the journey to get their children well as comforted and well informed as it possibly can be. It has been a tremendous honor to partner with Dassault Systèmes to translate much of engineering know-how that is commonplace in aerospace and automotive engineering and other fields, and really utilize these trusted tools to change how we think about, plan, and perform cardiac surgery. Thank you very much.